Hello, my name is Sran. I'm one of the NP students at Athabasca University. This is my verbal case presentation for Health Assessment 518. I'm going to be describing a client's visit to the clinic, which will include their chief complaint, history of present illness, past medical history, social history, their functional health patterns. This will be followed by objective data collected on their physical exam. I will start by describing chief complaint. Mr. S is a 56-year-old man with a history of hypertension who present with chest pain of 6 days duration. History of present illness. Mr. S was in his usual state of good health until 6 days prior to clinic visit when he began to experience recurrent chest pain. He presents to the clinic due to increase in frequency and severity of chest pain. The first episode of pain occurred with abrupt onset 6 days ago when he was working in his backyard in the middle of the day. He states he had been working for approximately 45 minutes and began to feel tired before the onset of the pain. He describes the pain as squeezing and pressure with tightness. The pain began in the substernal area and radiated up to his neck and left arm, but did not worsen with respiration and posture change. He rates the pain at 5 on a scale of 0 to 10. His pain was accompanied by diaphoresis, but no shortness of breath, syncope, dizziness, cough, nausea, or vomiting. The pain lasted approximately 2 minutes and resolved when he went inside and rested in cool area. The second episode of similar nature, chest pain, occurred while he was walking in the neighborhood with his wife about 3 days ago before the clinic visit. He rates that chest pain at 6 on a scale of 0 to 10, and it lasted for about 3 to 5 minutes. It was relieved by sitting down on a bench and resting. The third episode of abrupt chest pain awoke him from his sleep last night, and which is approximately 8 hours prior to clinic visit. The nature of pain was similar to previous episodes, but he rates his pain at 8 on a scale of 0 to 10, and it lasted for about 10 minutes. He tried resting, sitting up, and walking, but the pain lasted for 10 minutes before finally disappearing. Aggravating factors with previous episodes included physical exertion, but the patient was unable to identify any precipitation or aggravating factors associated with last night's chest pain. Mr. S denies acid reflux, throat burning, change in diet, or any unusual foods last evening. No recent history of trauma to chest, heavy lifting, or strenuous exercise. No recent weight change, fatigue, and change in appetite reported. No fever, myalgias, wheezing, dry or productive cough, dyspnea, and exposure related to his work, travel, and infectious contacts were reported. Mr. S also denies palpitations, trembling, shaking, fear of drying, paresthesias, chills or hot flashes, breathlessness, or choking sensation. Mr. S denies any active or subsequent chest pain since last night. He did not seek medical attention for chest pain after previous episodes due to their short duration. Medications and allergies. Mr. S is taking Ramipril 5 milligrams once a day. He also takes multivitamin tablet once a day. He had influenza vaccine vaccine in November 2019. No known drug allergies to medications and food. His past medical history includes hypertension, which was diagnosed 2 years ago, and he has been on Ramipril since then, which he states that he has been compliant with. He denies history of hyperlipidemia, diabetes, stroke, or peripheral artery disease. No surgeries or hospitalizations reported. Family history. It is positive for coronary artery disease, with father deceased at 54 due to myocardial infarction. Mother is 79, alive and well. No sibling diseases relevant to chief complaint. Functional health patterns. Mr. S was a smoker of 2 packs per day for 24 years and quit day, 2 years ago without any help. He drinks 4 to 6 beers over the weekend every week. He denies illicit drug use. He participates in monthly golf league but does not engage in regular aerobic or weight-bearing exercises. Social history. Mr. S works as an office administrator in large firm in Vancouver. He lives with his wife of 25 years and have 3 adult children who live on their own. He's concerned about the pain as if it gets any worse, it may start to interfere with his ability to do his job. Additionally, he's worried that the pain may be associated with his hypertension. Physical exam, general appearance. He arrived walking in no apparent distress. Well groomed, present, arrived without any accompaniment. Vital signs: temperature 36.8, pulse 90, respiration 16, BP 158 over 92. His height is 70 inches, weight 220 pounds, waist circumference 42 inches, and his BMI is 33.4, which puts him in an obese category. Now I'm going to review systems: head, ear, eyes, nose, and throat. Uvula, midline, pharynx without erythema, edema, or exudate. No orders noted. Remaining assessment deferred as unrelated to chief complaint. Neck flexible, non-tender. Trachea midline. Thyroid not enlarged, non-tender, without palpable mass or nodule. Chest, thorax non-tender with symmetric expansion. Respiration regular and unlabored without cough. Tactile fremitus equal bilaterally and greater in upper lung fields than lower. Breath sounds clear with adventitious sounds. All lung fields with resonant percussion notes. Cardiovascular. Apical pulse not visible. Apical pulse barely palpable, approximately 1 centimeter. Mid-clavicular line, 5th intercostal space without thrill, lift, or heave. S1, S2 present without extra heart sounds, murmur, rub, or gallop. I had patients sitting, supine, leaning forward, and left sideline. No apparent JVD and JVP approximately less than 8 centimeters with head of bed elevated at 30 degrees. Bilateral carotid upstrokes, brisk without bruise. No pain reported on palpation to midsternal area. Abdomen round, soft, non-tender, without rash, palpable mass, or organomegaly. Active vowel sounds, tympany over most quadrants with scattered areas of dullness noted upon percussion. Peripheral vascular, skin pink, warm and dry, and well perfused without edema, rash, or lesion. Nail beds pink, with less than 2 seconds capillary refill, no tropic skin changes or status notice. No abdominal bruise, 2+ radial, posttibial, and dorsalis pedis pulses. Neuro patient alert, oriented, and appropriate, moves all extremities, speech fluent, and words are clear. Patient is coherent, cognition and insight appear intact. Additional systems and maneuvers deferred at this time as unrelated to chief complaints. Summary statement: this is a 56-year-old office administrator with 3 episodes of left substernal chest pain over the last 6 days, rated 5 to 8 in intensity with associated diaphoresis. The first episode was precipitated by physical exertion in the backyard. The second episode emerged while walking in the neighborhood, and the third episode occurred at rest while sleeping. The patient has history of hypertension for 2 years and a 24-year smoking history of 1 pack per day. There is positive family history of coronary artery disease, with his father dying of myocardial infarction at age 52. There is no history of diabetes, but he's obese. His physical exam is unremarkable except for his blood pressure of 158/92. For further assessment, I'll be referring this patient for ECG. Thank you for listening to my video presentation.